Apparently Teresa at Ottawa U is there, and Christina in Perth as well, so welcome. There may be others, and just want to welcome you. These have been really interesting and beneficial sessions. Really looking forward. Dr. Bezaid is, I'll let him introduce himself, I guess, but I'll let his slide introduce him. But thank you for coming, and welcome, Dr. Bezaid, and we look forward to your presentation today.
Thank you. Yeah. Good morning again. So coming through the door, I saw, is this a class, kind of? Yeah, so it brought many memories from the past. I won't tell you how long, but here we are. So thank you for the nice collaboration between Algonquin, the other sites, and the Faculty of Medicine at University of Ottawa, specifically where I work, the Royal Ottawa Mental Health Center. And I was asked to present about depressive disorders, and I said, okay, by profession, I am a child and adolescent psychiatrist. I hope you don't mind. Do you have kids here at the college? But you do. So I said to Sarah Joint, who's our coordinator, is that okay? She said, I think it should be okay. Still, you talk about things related to youngers, but these youngers will be the future adults. So, and to be honest with you, when we talk about, thank you, Sarah. That's Sarah, what we were talking about. We saw all good things, so don't worry. So youth and young adult, there isn't, I wouldn't say there isn't any difference, but they're so much close. And though youth are still in the process of cognitive / intellectual, psychological, social, and physical development, and their brain, as you know, will not stop before, anatomically, structurally, before age 21, 25, depending. So we're still having like a group of youth into young adults, maybe sharing similar issues. And as a matter of fact, we will touch base on that when we come to the black box warning. It is not just applicable, when using antidepressant, it's not only applicable to the youth, but actually 15 to 25. So here we are. So I hope you don't mind to hear some of the stuff applicable for the younger ones. So this is me. I'm a faculty member of the University of Ottawa. I'm a child and adolescent psychiatrist, and currently I work at the Royal Ottawa Hospital. I have nothing to disclose. I have no relationship with pharmaceutical companies, so I'm clean. There shouldn't be any biases or anything. And I hope, looking at my watch, I would like to finish in a reasonable time where we can allow some wonderful, valuable questions and comments from your side. So forgive me if I quickly jump some of the slides and maybe focus on the what is immediately related to your practice. So hopefully we can cover some of the, get to know what is depression based on DSM, some epidemiology and statistics, and how to assess, what to look for, and we will conclude with some management interventions. Well, in DSM-5, which was published in May 2013, we waited long because the DSM-4 was released in 1994, and we waited really long, longer than expected, before we come to DSM-5. I don't mean to say that there has been a lot of changes, but there were significant changes. And just talking about depressive disorders, not anymore with bipolar under one umbrella. They're actually separated and makes a lot of sense. So right now in DSM-5, these are the main disorders under the depressive disorder, they call it nowadays. And as I said, they separated the mood from the depressive disorder, so the mood will include bipolar and bipolar related. Dysthymia, not anymore used, and instead they call it persistent depressive disorder. And there are two categories were added: disruptive mood, dysregulation disorder. This is more applicable to younger population. and there is the premenstrual dysphoric disorder, which I'm not going to talk about. Today, I'll focus mostly on the major depressive disorder. So why do we need to know about depressive disorder among young? Some people, even some professionals will say, oh, a 5-year-old, why would he or she be depressed? They're too early for life issues and what have you. But the truth is it has a higher rate of comorbidity. It's prevalent and recurrent, and accompanied, if not early detected, identified with poor psychosocial outcomes. And going globally, the depressive disorder in general, WHO identify depression as a common mental health problem. More than 300 million people of all ages suffer from depression. Depression is the leading cause for disability worldwide and is a major contributor to the overall global burden of disease. More women are affected than men with depression in particular. At its worst, depression can lead to suicide. And probably you've heard on the way coming to here, we were talking about how sad and heartbreaking to lose young people in our institutions. It's really sad. How come we were not able to identify them, offer the help needed? I know it can be very unpredictable, especially for someone who's very advocate, very active, highly functional. But again, something has to be done. Anyway, we're not here to talk about that, but just to tell you, do not underestimate the depression. There are effective psychological, and this is good news, compared to different disorders in mental health. There are many treatment modalities are quite effective, and what we like to call it the biopsychosocial. And the younger, I will say it up front now, and I may repeat it later, the younger population, we don't have to prescribe medication, especially in the mild, moderate, can be handled and addressed nicely with the psychosocial interventions. So this is very important to be said. To continue, depression is a common cause of school failure and school dropout. Needless to say, it causes, as I mentioned earlier, suicide behaviors, self-harm behaviors, substance abuse, especially these days where it is more accessible than our days, my days at least. And common answer when I ask the youth, 15, 13, 17, why are you using marijuana, which is mostly commonly used in Canada? It calms me down, helps me sleep at night, alleviate my depressive symptoms, control my anxiety, and so on and so forth, which is true, by the way. But long-lasting effect on the brain is more worse. Needless to say, it causes depletion of the dopamine, which actually worsens the depressive symptom. And that's what my answer to them right away. And I help them. I Googled with them to get, like we do it together in my office. Come and look what can cause to your brain at times. I do it. So substance use can be a cause or can be a self-medicating or self-medicating kind of that the youth sometimes or young adult can use it. Can also contribute or affect the physical the physical health, and can cause or lead to early pregnancy or unwanted pregnancies, and needless to say, as above mentioned, poor academic performance and so on. In Canada, and this is 2002, not necessarily outdated, depressive disorder is ranking the third mostly common in children and youth. All right, how do we diagnose major depressive disorder based on DSM-5? It's not a big difference from the previous DSM-4 or revised edition. We need one or two or both, either low mood or loss of pleasure, plus 4 other symptoms, total of 5 over a 2 weeks time every day. So loss of interest, or the other symptom can significant weight loss or weight gain, can work both way. Insomnia or hypersomnia, sleeping more. Psychomotor agitation or retardation, they are either staying home, doing nothing, have no energy, no motivation to leave the house, or they're actually more irritable, more agitated, can be verbally, physically aggressive. Fatigue or loss of energy, which also affect their concentration, diminished ability to think, and sense of worthlessness or excessive guilt. Not just like any one of us can experience at times or feel guilty, but the excessive ongoing guilt, that's a thing. And needless to say, the suicide ideation plans and associated self-harm behaviors. And there are different levels or before we get into that, having the symptomatology, the signs and symptoms is in one hand, but you have also to look for these are intervening with daily function, with the daily performance. So you would expect an impairment in their social, occupational, study, and so on, and also attribute maybe to their overall daily life and daily functioning. These symptoms should not be attributed to substance use per se or another medical condition. For example, hypothyroidism is known to cause depression, and this is one of the reversible disorders. If we identify that someone has hypothyroidism, hopefully by giving supplement and address the issue at the cause or root, hopefully the depression will be alleviated altogether. It is not better explained by other psychiatric disorders like schizoaffective disorder, schizophrenia, because patients with schizophrenia can also express or exhibit some depressive symptoms, so should not be confused with that one. And there has never been a manic or hypomanic episode. Otherwise, it will be called bipolar disorder, and it can be episodic, manic, hypomanic episode, or depressive episode. However, having said that the last one is quite challenging at times, especially with young population, because commonly youth, they present first with depressive disorder, different episode over months or maybe a year or more, but then one time something happens, either it was triggered or just this is the course, the nature of the disease. The patient will have one episode of hypomanic or manic episode. There we can say, oh, this is then a depressive disorder, but it started as a depressive disorder, but it's actually, in fact, a bipolar disorder. And we have to be careful, and this is something I will mention when I come to the biological intervention. We tend to be careful and we very cautious when we introduce antidepressant to youth, because we don't want to induce mania for those who are genetically predisposed to it. The best predictor for bipolar disorder is family history. So look for it when you dig for in the history. There are different levels, and these levels, its importance to help the therapists, the clinicians, the caregivers, is to decide which direction and how, what's the magnitude of the intervention should be. For a mild form, less or equal force symptom from the above mentioned, but importantly, no suicide ideation and no psychosis. The intensity of this distress is quite manageable. Versus the severe, I would expect suicide, maybe associated with psychotic features, and it's quite impairing. And in the middle is the moderate. Again, these numbers, to be honest with you, in my clinical practice, and I beg you, that many colleagues, they don't necessarily go like they're counting how many of these, but we take it in general, overall, and experience speaks most of the time. All right, what do we know about depression in children? So that what is said, that was in general, but what is specific about children and youth? Children, roughly, we divide them by 12 younger and 12 older. And even the adolescent age, early adolescence, middle and late adolescent. But again, is there any evidence-based well-documented differences between the two? Not really. But there are some observations, some accumulative reports that helps to differentiate or at least help us when we deal with a child of 5 years old, 10 years old versus 15 years old and 17 years old. Depression in children under 12 of age is less prevalent than among adolescents, has been reliably diagnosed as young as 3 years old. I haven't seen one myself, but this is mentioned. Significantly less evidence on the treatment of depression in children than their adolescent counterparts. Again, with younger one, no much studies has been done, and needless to say, long-term follow-ups on treatment intervention. And we will hear when we come to the management, specifically with the biological intervention, people are quite hesitant to introduce younger ones to medication. It took the psychiatrists, the mental health professionals, many years before they introduce or they allow this medication to be readily available and be used for younger ones. And we'll talk about it when we come to that point. All right, these are some, I hope this table will help you, some indicative for each group, but again, it's not conclusive. But for example, anxiety more common in younger ones. A child might come to you, someone who's 10-year-old, never been shy or afraid to separate from mom. Now they are not themselves. They're different. Or refusing to sleep in their bed and in their room. Things like that. Somatic complaints. Again, somatic complaints can be a bit challenging because it can be part of an anxiety disorder among children, but can be also true as an indication for someone who's depressed. Auditory hallucination, and I remember, at least in my practice, I've seen 2 cases where the primary presentation wasn't as an anxiety, wasn't somatic, wasn't anything else, but it was hallucination. And I remember that 9 years old, when I used to work at the inpatient unit at the Children's Hospital of Eastern Ontario, CHIO, they admitted a child 9 years old because she was hallucinating, and the hallucination was commanding her to jump off something, a bridge or something in her city or in her town. So that was, suicidal because of the hallucination. What could have been? Is it a tumor? Is it she was traumatized or abused? Is it? But through the admission, talking to the child with the team, myself and others, getting some collateral information, we learned that this is an adoptive child who was separated recently from her biological brother into 2 separate homes. And since then, her functioning declined, and she started to experience these hallucinations. So you can tell it wasn't a substance-induced, of course, for a 9-year-old, for God's sake, and not a tumor, not a thyroid or endocrine or any other problem physically. And we managed to work collaboratively, closely with the Children's Aid Society, and I'm happy that they were convinced that it's. Of course, they were looking for the best interest for these kids because the original family that they were both in together was not capable to handle although they were not like a troublemakers or out of hand, out of control, but for financial reason, they were not able to do it. But the Children's Aid Society, thankfully, they managed to support the family, and they got the 2 children together. And I haven't heard from them since then. And I assume no news, good news. So that was. All right. Have fewer delusions and fewer or less serious suicide attempts. They're not abstract at that age yet. Versus the adolescent, they may sleep more, they eat more, they have more delusions. But again, doesn't mean automatically that this is a depressive disorder with psychotic features. Not necessarily. They're more suicidal, more into self-harm behaviors, and they're more into physical, verbal problems, behavioral problems. And to compare to adults, as I said, more behavioral and fewer neurovegetative symptoms. So these are some of the things that just to keep in mind. But again, it is the mood and the loss of interest as the main flags that you think first, and then compare to baseline. How is their functioning? How is their sleep at the baseline? How is their appetite? How is their interaction? How is their school performance? How is their enjoyment into the regular hobbies and stuff like they do? And now, and how long has been the change? And then look for the trigger and so on. One thing I forgot to mention, and I'm glad I remember it, in children and adolescents, as well as in the other extreme of age, elderly, 65, 70 plus years old, they don't necessarily present with gloomy, low mood. They may actually present with irritable, agitation, anxiety. These are the first presentation. So again, don't be misled by, oh, this is just an anxiety of an old age, cannot find their ways and stuff like that. Same applicable, oh, maybe they're just afraid of school, or they're shy, they don't want to socialize and stuff like that. That's something to keep in mind. Some statistics and epidemiology, just for you to know, often under-recognized. Only 25% are diagnosed and receive appropriate treatment. We were talking, me and Doug, how many need for help, but how much is available for them. So I'm really happy that we have this collaboration so we can help these young men and young women. 20% of lifetime prevalence by the end of adolescent, quite relatively high. 60% will have recurrence by age 21. Male to female, 1-to-1 when they are younger, but 2-to-1 when they are older. So they join the adult population. Major depressive disorder, 2% in children, 4-to-8%. This variation in numbers depends on the methodology and design of the studies versus the dysthymia, originally known, or the persistent depressive disorder, which is the chronic depression. Just a few words just for you to understand it. So a major depressive disorder, you can have 2 weeks or more, an episode, and then in 3 months or less would either spontaneously resolve, the depression symptoms are alleviated, and then nothing, back to baseline, back to normal, and then may have another recurrence. Whereas in the chronic depressive disorder or the persistent depressive disorder, originally known or previously known as dysthymia, you would see the patient or the person with depressive symptom persistently experiencing and exhibiting these symptoms every day, most of the day, at least for 1 year for younger than 18, and for 2 years younger for 18 plus. With no, this is the condition here, with no free of symptom more than 2 months, all right? So every day, almost most of the day, for a year, for younger than 18, more than, for 2 years at least more than 18 or 18 plus, with no free of symptom of depressive symptoms more than 2 months. But another criteria differentiated from the major depressive disorder, beside the low mood and or loss of pleasure, you don't have to have 5 symptoms. Only 2 can be enough. And the impairment overall compared to the major depressive disorder can be less. And this is, we see it quite prevalent in youth, but sometimes can be not the true clinical depression, but can be subclinical depression. And this is not in the DSM, so I wouldn't confuse you with that. Now, is there any, or are there any risk factors for the onset of pediatric depression? And when we say pediatric depression, that across the line up to 18 minus 1 day. Low birth weight, so hypoxia. Family history of depression, this is a major factor. Family dysfunction or caregiver-child conflict. And there is, by the way, a diagnosis in DSM called parent-child relational problem. Under that umbrella, you can have a child with anxiety, depression, substance use, and all of the above, or all of the above. Exposure to early adversity, abuse, neglect, or early loss. Psychosocial stressors, peer problems, and victimization, bullying these days, and academic difficulties, especially with those who pass unnoticed, having ADHD/learning disorder, or both, or one at least. Gender dysphoria and homosexuality, especially if youth is bullied about their sexual orientation and sexual identity. Negative style of interpreting events and coping with stress. And this is very important. If time would allow, I would like to highlight it more, because it keeps coming, even in studies, like famous studies about youth responding to treatment, and youth are less likely to self-harm or to commit suicide. One of the major factors they found is that their ability of problem solving. The less the youth, needless to say the child, with less abstraction thinking, the less they have problem solving ability, the more into self-harm, impulsive acts into harm and causing problem to themselves. That makes sense, right? Okay. History of anxiety, I would tell you roughly, but don't quote me there, 70% of the time, when you have a depression, look for anxiety, and vice versa is true, right? History of learning disability, we mentioned that. Attention deficit ADHD. ADHD, only 1/3 of the cases, they present pure, just ADHD. Majority, I mean, when they present first time, because eventually, even if it's pure, only ADHD, eventually, if not treated, if they're not receiving the right proper treatment, they will fall into depression, they will develop the anxiety, and they will get themselves into all sorts of troubles. But the 2/3 of the cases, they present with anxiety and maybe depression, and plus oppositional defiant conduct disorders and learning disorder 40% of the time. Traumatic brain injury sets the stage for different things, but one of them is depression. Chronic illness, of course, someone who developed diabetes type 1 since early childhood, continue to suffer, to have issues adjusting with their illness, and any other problem. I just gave an example of diabetes. It's one of the common problems. Course and outcome. Depressive episodes range between 3 to 6 months for community samples and 5 to 8 months for referred samples. Again, these numbers doesn't make, to me, a big difference in practice, but it is how they present and how long does it take them before they get help. 1 out of 5 of adolescents continue to be depressed 2 years or greater. Risk of recurrence, again, the variation is quite big, 30% to 70%. That can something to do with the design and the methodology of the study. But 30% is still relatively high. So something to keep in mind. Suicide behavior is common, sequelae, as we said, of depression. Mortality due to suicide is elevated at least 10-fold compared to non-depressed youth. And depression is associated with obesity. You might want, I put it in red because one time I presented this or similar presentation and attracted a few audience attention. Why? Still not clear, but I believe something to do with this. Maybe one of them is the stress in between, because stress is the set stage for eating more and become obese. So that might be a reason. Release of steroid and its sequelae on our bodies. So that's one way to think about it. But to date, I even researched it yesterday, nothing to the best of my knowledge, unless someone came across something to tell us what is the relationship. It's not yet clear. Did anyone hear about anything? Obesity and depression? No. Guys, did you hear about it? No. All right. Now we'll move into what causes depression. If you notice, I have put those arrows in parallel. Means it's multifactorial and can be more than one at the same time. So there is no one single causal that lead to depression. Biological includes genetics, hereditary factors, can be at birth, as we said, hypoxia due to low birth, complicated at birth. Psychosocial, a famous one, especially with young population. Environmental can be inside our bodies during pregnancy or outside the big environment. And I don't want to bother you with this, but just for you to know that there are something out there people are looking for. Is there any genetic predisposition, any hereditary factors? The answer is yes. As you can see, 8 times in one of the studies, risk of major depressive for families, their parents had, one of them at least have depression, and there is increased risk of anxiety, conduct disorder. So this is not specific for depressive disorder, but in general. And it was also demonstrated clearly in adoption studies. So if you take a child away from the biological family to adoption study, there can be also not only genetic factor, but also the risk of the environment, which can be as powerful as well. We mentioned the sexual abuse, neglect, exposure to domestic violence, that again set the stage for depression and maybe others, anxiety. I tend to see them, they're presenting anxiety, depression, and maybe post-traumatic stress disorder as well, and so on. All right, some, again, is still theory. There aren't any conclusive, I would say, data to say, or causes to say, this is the reason behind the biological, the clinical depression, but just I'm presenting for you to know. Even myself, I'm not fully aware of all these details. Now, we're actually approaching to my second half of the presentation, and we have only 20 minutes. So hopefully we can manage, and what to look for. And again, this is not just a psychiatrist's job. This can be any frontliners. Can be a clinician, a social worker, a psychologist, a family physician, and of course, part of a psychiatrist's job. So what to look for? Information obtained from multiple sources, quite important, especially with younger people. Needless to say, home, whoever is that home is, whatever is that home is, but also school, very important. These two, because children, adolescents, they spend at least 8 hours in school and in a school environment, so we need to know from them. Review of psychiatry history, if any. Review of medical history, as I mentioned, hypothyroidism can present itself as clinical depression. And with other psychiatric disorder, hyperthyroidism, the opposite, it actually can present as an anxiety. Chronic, like recurrent asthma, early age, can also present with anxiety. Hypoxia can lead to different sort of things. So anemia, iron deficiency anemia. These are some examples you might want to do. Vitamin D, vitamin B12, and so on and so forth. Review of developmental history, any history of separation anxiety, any history of abuse early on, neglect, and so on. Review of academic history to tell if this patient has changed from baseline, but also to ask yourself whether this patient is suffering from learning disorder, from ADHD, which led to the current presentation of him or her feeling depressed or anxious or both. Review family history, very important, as we mentioned earlier, the genetical predisposition. To continue, assess for other comorbidities. Again, 70% of the time they present with both depression and anxiety. Assess mental state and physical examination. This is the actual evaluation in the clinical setting. And look for any severity, any signs of severity or impairment. Sometimes we use some diagnostic instruments, but again, the primary diagnostic tool is you talk to the patient and gather information from them and from their collaterals. These tools are not by them, like you cannot just run a scale and say, oh, I can diagnose based on that scale. No, you can't do that. We quite use it as a baseline indicator of how severe it is now, and then we repeat it and we follow it up to see if there is any response to treatment. And as I said, some blood works to tell if there is anything deficient, can be corrected, and we can reverse the depression. And I put it in red because very important. If you have only 20 minutes to see a client in your office, don't miss to assess the safety. Some people, they don't volunteer telling you that I'm not feeling safe because they see it as a stigma, that I'm not strong enough. Or maybe ending my life is the best solution. Because when someone is in that depressive mode, they don't think properly. They lose their abstract thinking. They don't see the brighter side of the equation. And unless you talk to someone with depression, you might not appreciate what I'm saying. So it is very important gently to check on that thing and go around it, ask a few questions. You don't just ask, are you suicidal? No, I'm not suicidal. Okay, next. Try to look for it and pick on it from a different angle and so on. And once you see something that you're worried about, leave everything else and just focus on that thing. And hopefully you can help and prevent a loss of a soul, an important soul actually. Assess level of care because again, especially some of your students here in this college or the other sites, they come from out of Ottawa. They don't have much of support. They may not necessarily get into, like they've been lucky or successful to make friendship. So it is not easy to move, to settle, to start this, a study at post-secondary. And I know what this means. I went through that, so it can be really challenging. So offering the help is quite important. And assessing and looking for it is where you start first. Needless to say, we need to look for any other differential diagnoses, and these are some of them. Just out of care for the time, I'll skip that one. Also talking about the comorbidity, I already mentioned few. And just one thing quickly for you to know, risk for bipolar disorder, any early onset of depression, family history of bipolar, depression accompanied by psychotic features. These are some of the things make you think, oh, could this be a case of bipolar? And if you have had any doubt, make sure you don't push the dose of the antidepressant quite high in a short time. Take it gently, start low and go slow, and then monitor the progress as you go. And we will talk about it. Management. This is the last component of my presentation, although it has a few slides, but we'll try to do it as quick as possible. As you notice, I put safety number one, even before medication, before psychotherapy, before anything else. Because what's the point of giving a medication where in fact he's already or she is already determined to end their life? So make sure they're safe, they're well supported, work with them on safety measures and safety planning. Make sure the home environment is safe. There are no access or easy access to tools or ways that they can use it in their low moments, in their sad, gloomy, dark moment where they may end up their life. And these are some of the things. And even the best way is to actually do this exercise together with the client in your office before you go. And sometimes we even develop a contract. And that contract can be communicated or should be communicated with others who knows and she or he feels comfortable to share it with. A few things about suicide. I'll leave it to you to read, but let me ask you this question. Whom do you think uses the most effective method of ending their life? Boys or girls? Again, it's roughly, it's not like conclusive evidence-based, but the equation of 9 and 1. What is that 9 and 1? What do you think? Till I get a sip of water. Think about it. 9 attempters versus 1. The girls, they attempt 9 times before they do it successfully, whereas the boys only attempt 1 time. And the next one is successful. So you have to be careful with that, yeah. But again, this is rough indication. Profile of youth with complete suicide. This came from the TAD study and other studies. Do you remember when I mentioned about their level of their immaturity or lacking the ability of problem solving, very important. Because as I said, I worked at CHU in the inpatient. I used to, and as well my colleagues, to have at least 20% of the admission of those recurrent, we call them between us, the frequent flyers. The recurrent, we do? So we have them, they come always like with suicide ideation, self-harm behaviors. And I developed, and I feel confident, some of these guys are quite desperate, but the only way they can think of ending my life. Not necessarily they mean to end it, but something, they're crying for help, but in an immature way. And when you talk to them, but what about, think about this or that? I never thought of it. How about calling or reaching for help? That's why the one fundamental intervention we do as an inpatient in the crisis unit, and if someone needs extended admission, we transfer them to the Royal Youth Unit, is to work on developing healthy, strategic coping skills. So when you're in that low moment, you apply those skills. And I wish we have more time to talk about them, but if any question can come, I'll be more than happy to talk. Protective factors, very important. As much as you teach the youth or the young adult how to cope, what things should be done, it is equally, if not important sometimes, is to work with the client on the protective factors. So the relationships, the support, talk to the school. Yesterday, I received a phone call from a mom about her daughter because she needed that letter to support her with the online study. I can't say that, well, it's not my business. The school is the one to decide. I have to be very innovative in a way to go one extra mile to help these children. And there are many stories I can share with you, if time allows, how the school can play a major role in reducing those anxiety leading to depression, or depression with the anxiety, or all of the above. So working with the school, and when I say school, the second, like the elementary, second, but also post-secondary colleges and universities. Some of the clients that I've seen through telemedicine, they're quite stressed, so they need sometime accommodation around exam time. They need accommodation, how many credits they should be taken. Even the way to be evaluated and how they, what the expectation and so on and so forth. Because they are not any less than anyone else, but they have some learning difficulties. So we need to accommodate those needs. And some youth in Canada were from people from all over from everywhere. They come and they settled. Some settled many years, but they still keep to their affiliation, to their religion, to their faith. It's very important to respect it. It's very important to work with it. You don't have to believe it, but at least to work with it, because it can be a very powerful tool to keep them functioning or to keep them alive. I will skip this because I need just to spend some time talking about the biopsychosocial intervention. A question to you. Which of the following, this is a multiple choice question, we're in the university, so. Which of the following antidepressant is approved for children and adolescents in Canada? Who thinks it's fluoxetine? Hands up. Or the next one, or the next one. Any answer? Don't worry, don't shy. Huh? Fluoxetine. Thank you for being, any other answer? Yes? Zoloft? All right. Any other answer? All of the above? Dog. I don't like paroxetine. I told my student, it's not my favorite, so. For youth, for younger children, none to date approved in Canada, and they have their good reasons, and it's beyond today, this lecture. However, our neighbors down, US, they approve, as you can see it, fluoxetine, so you're right in a way, for children 7 to 17, and it's the only country they approve it also for 12 to 17. Sorry, to 7 to 17. So everyone else, 12 to 17, except in the US, they also approve Prozac for 7 to 12. And the second one is escitalopram, Cipralex. The rest are off-label, but again, in practice in Canada, we do prescribe this medication, but as I will come in a minute, how to prescribe it. And this is the famous study, still one of the leading studies in the field, to tell you what they have done compared. There were 4 arms. They have given youth Prozac alone versus CBT alone, cognitive behavior therapy, versus a combination of both, my favorite, and the last arm or the last group was just placebo. What happened? And in 12 weeks, which is relatively early stage, unsurprised, as expected, the combination did the best, not that far from the combination. The medication was also next, but not much for the CBT in the first 12 weeks. And that is quite understandable, because to have the effect, the positive effect of CBT, you need some time. You grasp the information, you apply them, and then you see the result, and then you believe in them, and it's part of you now. So it takes some time. And of course, the placebo was the lowest. Surprise now, in 18 weeks, they're almost the same. Very surprised, and I don't know why I'm missing the last one. The placebo, even if you have those 4 arms, the combination was quite separated from the placebo, but at 36 weeks, they're almost close. And this is one of the arguments why Health Canada, do we really need to expose these kids for a medication that eventually may not do them any difference than the placebo, number one. Number two, I'm not here defending anyone, but I'm just sharing with you what I think their argument is, and quite reasonable. Introducing this medication is, with evidence, can improve the depression, but there is a price. And we will talk about the black box in a minute. So the price, it might increase the suicidal ideation. But we'll talk about it. Just bear with me, please. Anyway, we have to jump just quickly. Other than the SSRI, the Prozac, the citalopram, the Zoloft, some people like the Paxil, and the others, none approved for younger population, not like the adult population. However, in practice, how we do it, we start always with SSRI, serotonin-specific reuptake, like Prozac, Cipralex, Celexa, and so on. We try it adequately. When we say adequately, optimal dose, optimal duration. If it doesn't work, then we try another one. After 2 failed trials, we go to another group, the SNRI, serotonin, norepinephrine. Example of it, Effexor, venlafaxine. If that doesn't work, then we go to another group that works on the dopamine. You remember when I talked about the marijuana? So that's another one, like bupropion, the Wellbutrin. And there are other medications, but these are just these 3 groups come up like almost like a 20 different antidepressant. So, or maybe less. Don't quote me in my calculation here, the math. All right, we don't use did I mention that? Yeah, we don't use no more the tricyclic antidepressant. Doesn't mean we don't use them, that they're not effective. They're quite effective, in fact. But their side effects, their narrow toxicity window scares us. Because if someone overdose on Prozac versus someone overdose on amitriptyline, the first one may pass unnoticed, in fact. Maybe. Like we see some kids, okay, I overdosed. When was that? Oh, 2 days ago. Okay. Still, we have to do something. Whereas amitriptyline, no. It will take them into a severe, complicated emergency physical problem. So it's narrow toxicity and quite lethal. That's why we don't use it anymore. That's not because it's not effective. They're quite effective, and in fact. Besides, the side effects are quite unbearable. Like the dryness of the mouth, the sedation, the hypotension, the anticholinergic side effects, central and peripheral, and what have you, makes us a bit hesitant to prescribe this medication. Now, I just want to quickly talk about the black box warning. 2003, there was like an epidemic of kids, youth introduced to this medication, reporting increased suicide. So everyone panicked. Even, if I'm not mistaken, Britain, they held prescribing this medication till they find out what's the actual cause, the root of it. But in 2014, it took a year for independent authorities and organizations and institutions to examine this issue carefully, not being affected or biased by any pharmaceutical company. They came to conclusions, which is, it is not contraindicated to prescribe antidepressant. However, there is true increase of suicide ideation, 2% with antidepressant versus 1% of placebo. It's not a big difference, but it's worth looking and worth taking care of that. And there were many recommendations. Among them is to start low, go slow, monitor for the suicide ideation. So if you prescribe it today, it is highly recommended that to see the youth within 2 weeks, if not earlier, and then to check him out if possible every 2 weeks, at least in the first 6 to 8 weeks, because this is the peak where this increased suicidal ideation happens. But to date, there is no complete suicide, thanks God. So this is good news. And the British people, when they held it for a while, what they found, and elsewhere, maybe now don't quote me here, maybe it's in Singapore as well, what they found, the suicide rate increased or doubled when they. So when you prescribe the medication, there is a concern, but if you don't prescribe medication, the suicide increase even doubled or tripled or maybe more. So I'll probably have to conclude by here. I have few slides, but about CBT, interpersonal therapy, but I would like to have some questions and comment. But this is a nice summary I want you to remember. For mild to moderate, for youth and younger, needless to say, psychotherapy, psychosocial intervention, support to the parents, to the client, with colleagues, at the school, outside, at home, is very important. And you don't have to prescribe medication. However, moderate and severe, always the recommendation to go with medication with big plus, a combination of something else. Can be CBT, can be IPT, can be problem solving, safety strategies, as we mentioned. I think we're done. Questions and answers and comments, please. I welcome it. And forgive me that I didn't finish my remaining slides, but I mentioned a few things through the presentation, hopefully. And with your valuable question, I'm sure we can cover that up. So please, go ahead. Do we start with outside side or from inside? Or?
Just inside for questions. I don't know if you had any stories or comments around, because you talked about the safety plan and the ability to problem solve. But I run into issues when I'm dealing with students that are on the spectrum.
Okay.
Right, and that impulsivity in regards to their behaviors and the inability to self-soothe and to have, coping skills. But presents very risky in regards to suicidal behaviors. So I don't know if you have any.
You know what? I expected this to come, and this is very important. And if I may suggest to Sarah and Doug, have someone to talk about this specific. It's worth. Catherine Madison is excellent, or Allison Kennedy, Dr. Allison Kennedy, from the. I thought it was over there. Okay, part 2. we can have them come and talk about it, because it's a very important question, and this is what you need to do. So if we can just highlight a few things. Number one, if someone is coming to say, I'm suicidal, so the first thing that you want to ask yourself, what led them to become suicidal? So try to understand that. Then you go to a next step, trying to understand is it a safe environment around him, her? Who else in relation or close to this person? So try to help him to identify those personnel. Not everyone, they will feel comfortable. It's okay, but at least one. But if none, you'll be surprised. Sometimes, at least with youth, I don't like to talk to my mom. I don't like to talk to my dad. I don't trust them. They will react. Again, they care about their parents. But for young adults, maybe they're away from their families. And I don't expect them, Mom, and she's 400 kilometers away, I'm suicidal. Poor mom, what she'll be doing there? So they may not like to talk to their people around them, but at least identify what led to this, and then try to understand the environment. Number three, to identify the personnel that this person can reach for help. If none of the above, there are some like hotlines, some numbers to call 24/7, and the least to be done is to report themselves to the emergency, of course, to call 911 if they cannot make it. They're so tired and they're so depressed. But also, maybe through the sessions, once you identify these issues, and maybe depending on what led to that depression, subsequently to that suicide, you work around it. Some of the strategies are cognitively embedded, and some are actually can be through behaviors. You just apply simple, concrete behaviors, distraction strategies. And if you think that I will conclude with that, if you think that is highly suicidal, and I do it sometime, I prescribe the antidepressant 7 days at a time. So you don't give them a month supply that easily they can do. Did I answer that? I'm sorry, I haven't maybe applied it all, but yeah.
Yeah, that's enough.
Okay.
Thank you.
No questions means you either understand it all well, or maybe I did not do a good job.
And just curious how you approach treatment-resistant depression.
All right, good question. Buy this. No, I'm just saying. All right, if someone is not responding to treatment, and be it biopsychosocial, first you revisit the whole diagnosis. Am I dealing with the right diagnosis? Maybe I'm missing something here. If still after revisiting the symptoms, the signs, and the history, talking to collaterals, it confirms your diagnosis, look what you have already done. So assume it will be much easier if we have an example, but let's say you've tried one of the SSRI. Then the next step is to try another one, providing it's that you reach adequate trial. And I said it, optimal dose, optimal duration. Optimal duration for depression, at least 4 weeks. An optimal dose varies between one person to another, but each and every medication, we have a max dose per kilogram. So, for example, sometimes we treat with Prozac, there is nothing wrong to reach as high as 40 milligram, and sometimes I go for 60 milligram before I say it's not working. And at least 6 weeks that they're taking the medication. Also important to ask the patient, and hopefully you have an honest, open relationship, she or he are actually taking the medication, because there is a tendency among people, they're tired, they're disorganized maybe, they forget their medication. So consistency, compliance on medication is a major factor. So providing that they're doing it adequately, and you tried one medication, try another one again from the same class. But I also always like to say medication is one thing, but the other psychosocial aspect has also to be addressed. If problem with his academic performance continues to be the case, no matter what antidepressant you're given, he will not or she will not be responding well to that. So if it happens, you're part of the health center, if you're one of the clients, work closely with that student and the teachers or whatever try to help them resolve their issues with the academia and provide some support in that regard. So providing that we revisit the whole diagnosis, we try the optimal treatment biologically, but also resolve and address all these psychosocial components. I think that is, and if it doesn't work, then go to another one. And sometimes it takes many trials, and it takes longer than expected before we reach to hit the right medication. We wish, although it is happening, but not commercially yet. They take part of the saliva, they examine it, and they can tell you, oh, your gene, you'll be responding much better to, let's say, Cipralex versus Prozac. Whereas somebody else will respond to Effexor. Let's say that. All right? All right. No, we don't want to deprive them lunch. Food is important.
It's been a little bit like drinking from the proverbial fire hose today, but thank you. Thank you. This has been wonderful. And just a small token of our appreciation. Thank you.
Pleasure.
And thank you so much for being here, both present and online. And I know a number of we'll probably have to get going for either appointments or for lunch, but it's been a very good morning. Appreciate it very much.
Pleasure
Thank you.
is mine, and thank you for having this. All right. Thank you, Sarah. Pleasure, always.
It was suicidality and the spectrum. That would be what the psychologist and Captain Madison. This is the tomorrow, tell me that I'll write it down and follow up with people. They talk about risk assessment. The other one that came up sort of